So I've been at Baylor since the War of Northern Aggression. It's been a very long time. So following in Clay's footsteps, I'm going to now do an encyclopedic review of every bacterial, fungal, viral, and parasitic infectious disease known to mankind, and I can speak as quickly as he can, but that's not what I'm going to do. Because this conference is really supposed to be built around the integration of dermatopathology, and I would say other lab services to dermatology, what I chose to do is do a little different tack. And I'm going to go a little slower, and I'm going to give you 10 ways to be serenely happy with cutaneous infectious disease and try and highlight how the lab integrates with that. And yes, we will talk about some infections that are sort of nasty, but some that aren't. And I'm going to do this largely in a case-based way so that you'll see how the dermatologist and the dermatopathologist and other lab services combine their expertise to come up with a happy solution. Infections aren't always happy, of course, but used to be the #1 cause of death in the year 1900, and by the year 2000, 100 years later, it's the 4th leading cause of death, and usually much, much later in life instead of an average life expectancy of about 40. Of course, now it's over 70 for both genders. I have no conflicts of interest. So, 10 ways you can be happy with infectious diseases. #1 is to verify that it's infectious. I have 3 patients here. I want you to look at them very carefully. A 24-year-old febrile female, a 28-year-old febrile female, and a 35-year-old afebrile male. They all look a little tiny bit different, don't they? Which one of these is infectious? How many think it might be A? Raise your hands. Nobody's grading you. Nobody's looking. Okay. How many think it might be B? How many think it might be C? Okay, good. You're all wrong. Not a single one is infectious. I have lupus profundus, which we've already heard about. I've got an atypical pyoderma gangrenosum, or whatever you want to call bullous sweets associated with acute myelomonocytic leukemia. And I also have a granulomatous inflammation of paniculitis from a man who is trying to change himself into a woman by injecting silicone into his breasts and into his thighs. So that thing that looks like cellulitis is actually an inflammatory reaction to silicone, which we've also heard about. So here are the messages. Just because it looks like an infection doesn't mean it is. There are clinical mimics. No matter how astute the clinician is, things can look like an infection that aren't, and things that don't necessarily impress him as an infection might be. And that's where the lab is very, very helpful. The clinician should always attempt to ensure that something's infectious by confirming it, whether that's direct observation of the organism, like doing a Zank smear or a Gram smear, or through laboratory services, which include pathology, microbiology, and serology. And I think the most important thing, this is kind of a 55-45, 60-40 crowd, clinicians versus those who are primarily self-identified as pathologists or dermatopathologists. But I think for the clinicians in the group, it's really incumbent upon us to supply the laboratory personnel with enough information so that they can make good decisions. And, you know, red rash is sort of not enough. It just doesn't cut it. Red rash and fever, maybe not enough either. And I'm going to give you some examples along the way where some of these additional bits of information were actually critical in real life situations. So, #1, cutaneous infectious disease, you have to prove it's infectious. You can't just guess. That's stupidity. That's for fools. #2, A, think infection when, if you're a clinician, you're staring at something for more than 60 seconds. Like, I don't know what the hell this is. Think infection, because infections can cover a wide gamut of morphologic manifestations. Read sometime the differential, the things that histoplasmosis can look like, for example. Everything from molluscum contagiosum to a cellulitic to a paniculitic morphology, along with bumps and lumps of all sizes, and even something that looks like acne. So when you're staring at something and you say, I don't know what the hell this is, think infections. So here's an example of that. This is a 28-year-old Hispanic female who came in with this rash on the forehead. It is totally asymptomatic. It's been there just a couple weeks. It was biopsied. I will tell you, my first impression is that this is an accumulation of stuff that doesn't belong there. Like I was thinking lymphoma, possibly. And the biopsy came back as a very mixed inflammatory, dense inflammatory cell infiltrate, including everything, plasma cells, lymphocytes, histiocytes. Now it's interesting, along the way, part of the history that the resident obtained was that she had had multiple episodes of unprotected sexual intercourse. Her review systems was totally negative. She felt fine except for this rash, which didn't even itch, burn, sting, or hurt. Because of that history, and because the biopsy was really nonspecific, we went back to the lab and said, can you do anything just to see if this might be syphilis? And sure enough, with that history and with that request, they did T-pallidum immunohistochemistry, and it was loaded with the organisms. And then we did a serology, which was 1 to 512, and then she was treated appropriately for secondary syphilis. So I'm staring at it. I don't know what it is. Always keep odd infectious diseases in mind. Keeping in mind, syphilis is now fairly resurgent. And the last 3 years, the numbers of primary, secondary, and early latent infectious syphilis have gone up from about 14,000 to 15,000, now over 16,000. And by the way, is anybody here from Georgia? You are now the most syphilitic state in the country, replacing Louisiana, I might add. Now, immunohistochemistry, in this case, made the diagnosis of syphilis. We would not have known that otherwise. And so I want to point out for the clinicians and reinforce for those who are in the pathology sphere that molecular diagnosis is really in the forefront. And these are powerful, powerful tools. And this was a very, very nice article that sort of summarized that. And I've excerpted, this is not from the article, this is my own little excerpt from that article, looking at where immunohistochemistry can help, where PCR can help, where in situ hybridization can help. And you'll see there are bacterial diseases here, there are parasitic diseases here, there are viral diseases here, there are fungal diseases here. And many of these diseases are not easy to diagnose. Now, it's best, the molecular diagnostic techniques are probably the most, today, are probably the most refined and the best for viruses. They're not too bad for fungi. They aren't always that great for bacteria. When I say better, I mean they're more reliable, they're more widely available, and they're cheaper. The one exception to bacteria is mycobacteria, and I'm going to show you a really good example of that in just a second, why it's so important. But in general, that's kind of how they sort out. But there are always tests available for selected organisms, and they should be tried when the clinical situation dictates. Now, when are these molecular diagnostic tests going to be done? First thing, if you mention infectious disease in the differential diagnosis, and the dermatopathologist sees a pattern that's consistent with but not diagnostic for an infectious disease without identifying specific organisms, they might think from your submitting, the clinician submitting a differential that includes infectious diseases, I should check appropriate molecular diagnostic techniques. So part of that depends upon the clinician, right? They might do molecular diagnostic techniques if the histologic findings, regardless of what's on the differential diagnosis or the submission sheet, if the histologic findings to the dermatopathologist strongly suggest an infection, but clearly the organisms are not obvious. So the histology might lead to this. And then third, might be done if the histology is complete enough, and it's really, the history is complete enough, excuse me, and And everything else is kind of vague, but the history really, really suggests it. So all of these ways the molecular diagnostic tests might be done, depending on what you, the clinician, put on the slip, what the pathologist sees under the microscope, or what the history is, regardless of any other factors. All of those ways can lead to these powerful tools. So in this case, Treponema pallidum was identified and the proper diagnosis was made. Aside from staring at something for a long time and not knowing what it is, if you're a clinician and what you're doing just isn't working, think about infection. Because if you're not treating it for an infection, you're not treating the proper thing. I think this is a really good rule of thumb. Rethink your diagnosis, period, if your treatment isn't working like it's supposed to. But it's especially poignant for infections. Let me give you an example. Here's a woman with a widespread eruption, right? It is clearly annular and it is clearly scaling. It is all over her V chest, her upper arms, there's some on her face. She was actually seen by her primary care physician who felt, it's round, it's scaling, it's got to be ringworm. So he gave her clotrimazole cream to apply, which she did diligently, and it didn't get better. And her sort of routine labs were okay, so he said, go to the dermatologist. So she went to the dermatologist. The dermatologist, being brilliant, said, this must be subacute cutaneous lupus erythematosus. It's annular, it's scaling, clotrimazole didn't work, so I'm going to send it in. And on the path slip, it said annular eruption. Rule out subacute cutaneous LE. In the meantime, the rest of some blood work ordered by the astute dermatologist all came back negative, so there wasn't much suggesting LE, but in subacute cutaneous LE, you might not have any of these positive serologic tests. The biopsy came back very nonspecific, perivascular lymphocytic infiltrate, nothing really involving hair follicles, nothing involving deeper vessels. But on careful examination of H&E slides and with special stains, the astute dermatopathologist saved the day. And the dermatopathologist said, I'm so glad you included the word annular in your submission because the routine histology was very nonspecific. But when I went back and looked carefully, I could see hyphae all throughout the epidermis in the stratum corneum, consistent with a dermatophyte infection. Oh, but wait, you say, the primary care physician gave this patient clotrimazole, and they didn't get better. Well, now going back to the patient and getting some additional information, it turns out she has a new kitten, and now a little scraping in a culture showed Microsporum canis, and she was treated with naftalene cream instead of clotrimazole, and her subacute cutaneous lupus miraculously went away. So, first of all, the message is involved here. Tinea can mimic subacute cutaneous lupus, or vice versa. So there are clinical mimics, as we've already said. Microsporum species are much less responsive to the azoles than they are to the allylamine antifungals, and even though she used an antifungal, it just wasn't enough to get rid of her infection. And also, I now ask routinely, it's part of my intake form, and if they don't fill it out, I ask them what exposure they've had to animals, including household pets or other animals. If it's someone single, you also have to ask about the pets in their boyfriend or girlfriend's house. Or do they care for animals? Do they babysit? Or do they work in a zoo when they're exposed to animals? So animal exposure is an important part. Zoonoses, I don't mean the really obscure, bizarre zoonoses, but fairly commonly transmitted diseases from animals to human beings are not that uncommon, and they aren't always clear-cut from a clinical standpoint, and history helps. And word your biopsy slip in a way that the pathologist knows what you're seeing grossly. If I just said rash, rule out subacute cutaneous LE, and I didn't say the word annular, it is conceivable on a busy day with 3,000 slides to read, the pathologist might not have gone back and looked very carefully at that stratum corneum. But the word annular, clicked a little button, think fungus. Not everything that's round is ringworm, as we know, but in point of fact, it clicked a little button, that prompted a little extra time on that slide that gave us the diagnosis, that gave us the therapy, and ended the patient's misery. So ask about pets and word your biopsy slip appropriately. Okay, identify specific organism if you can't be sure. So here's a child who presented with a fluctuant tender nodule in the neck. If this isn't an anatomical abnormality, which usually appears a little later, branchial cleft cysts and things like that, thyroglossus duct cysts, which are in the midline and most commonly later in life, then the most common thing for this is going to be a bacterial infection and frequently a mycobacterial infection. This patient was in good health. It's not immunocompromised, not immunosuppressed. So the thing that was done initially was an aspirate of this fluctuant tender nodule stained with acid-fast stain, positive. So it's an aha. It's a mycobacterial infection, right? Except that's not the end of the story, because this could be Mycobacterium tuberculosis, it could be Mycobacterium scrofulaceum, it could be Mycobacterium haemophilum, which is a new, relatively new pathogen, which is commonly seen in children of this age who are totally healthy, probably related to inoculation, possibly inhalation. Nobody has a foggy idea, but it's becoming a common pathogen. And if you notice, it's very critical to know exactly what this is, because the therapy, if it's MTB versus M. scrofulaceum versus M. haemophilum, are totally different. So even when you know kind of what it is, you have to know exactly what it is, because that way you get definitive therapeutics. So you can do this in multiple ways. Right now you can rely not only on the path lab, but you can rely on the micro lab, and you can say, well, I want to do a mycobacterial culture, something on appropriate media under appropriate conditions, and you can wait 4 to 9 weeks to get the result. There are newer mycobacterial, particularly culture medium, where you can now get the result in 2 weeks or less, sometimes in 4, 5, 6 days. That would be very helpful. And if you're in a situation like this, especially with a child who looks like that, especially with a mother who's the richest woman, second richest woman, maybe the richest woman, they debate between themselves, in the entire city of Houston, you want the answer like as soon as possible, because she's calling hourly. Do you have the results yet? Shall I call my attorney? Do you have, my child has a bump. You better fix it. Shall I call my attorney? Next phone call. Do you have the results yet? An hour later. So you want the results as quick as possible. So you might have to tell the microlab, do you have the new quick, rapid mycobacterial culture things? Because I know it's a mycobacterium because my dermatopathologist stained a little aspirate for me and found acid-fast bacilli, but I need to know which one it is so I know how to treat Muffy's little kid. So that's important. But even faster, if your dermatopathologist or pathologist has the capability, is doing PCR for mycobacterium, because you can find this out in a matter of hours, and you can be very specific about it. So you have to work with the laboratory individuals, whether it's dermatopathology, pathology, or microbiology lab, in order to get specific diagnoses. And you can even enhance the rapidity. Where it doesn't count, it can take. Who cares, right? I'll figure it out. It'll come back. But sometimes it's very important, not necessarily for the superficial reasons I enumerated that apply to this case, but sometimes it's life and death, or it's really a critical decision. Number 4, even if you're sure the diagnosis, know what the organism is. I'm showing you this foot, right? This is an undocumented Mexican national. It's enlarging, it's tender, it's painful, it discharges some granular looking stuff, he's in good health. What's the diagnosis? Starts with an M. Mycetoma, absolutely, right? It's mycetoma. Everybody in the room should know that. But that's not the end of the story, right? You know the diagnosis, but is it a eumycetoma due to true fungi, or is it an actinomycetoma due to bacteria? And again, the therapy varies quite dramatically between the two sets of the same general diagnosis, mycetoma. So in the last case, we knew it was an acid fast, but you need to be very specific. And you weren't really sure it was acid-fast till at least an aspirate was done and stained. Here, the diagnosis is apparent to almost everybody, especially with that history and this clinical morphology, but you can't stop there because you have to really go one step further. Get help when you need it. Get help from anybody who will offer help. This is a lovely young lady, 24-year-old graduate student at Texas A&M University who's had a facial eruption for 13 years. She had a biopsy done by one of my classmates, somebody who's in residency with me. The biopsy was read as eczema, and she's been applying mid-potency topical steroids to her face for 13 years. Not only does the eczema not go away, but it's actually slowly spreading. And after 13 years, she decided she wanted another opinion. That was after her family doctor said, oh, those dermatologists are stupid. This is really erysipelas, and gave her 3 different types of antibiotics over about 2.5 months, and that didn't get her any better either. So clearly something is amiss here. Eczema and steroids don't make it go away, and it's actually getting bigger. Asymptomatic, but certainly a bit indurated. I think you can get the feel from looking at this patient. So a new biopsy is done. Notice I put sutures in my biopsy. I don't slop Mon cells in there and give them a black tattoo. So that's my biopsy. And this biopsy was read by the director of this course. I don't know if he'll remember that. But it's a granuloma, and then because he takes a while when you see something that looks sort of interesting, he found this. And the report back from Dr. Cockrell said, I found fungal organisms, but it wasn't clear-cut. It wasn't like a zygomycete that's aseptate. It wasn't clearly something that looked like aspergillus. It wasn't clearly any of the deep fungi. I don't know exactly what it is, but it's fungal. And he said to me, do a culture. So I went back, got another piece of tissue, and did a culture. And here's her culture. It's a dematiaceous, dirt-looking fungus, and its microscopic appearance is very interesting. It looks like brown Pac-Man, and this is characteristic of phoma. Phoma. Who saw a phoma last week? Who's ever seen a phoma clinically? That's what I felt like. So what's a phoma? What do I do now? It's a plant pathogen, and it causes the leaves and the stems of certain plants to go crazy, and it's a crop blight. It interferes with crops, things like beets and tomatoes and peppers and stuff. But it's rarely the cause of human pathology. So I went to the largest infectious disease textbook I could find. I opened up phoma. What do I treat it with? It said, phoma, good luck. There was no help. I went in the literature. There were so few cases, it was of no help. So what did I do? I went back to the lab, this time to the mycology lab, and I said, you got to set up some sort of susceptibility testing. Now, there really isn't an approved susceptibility testing for saprophytes and dermatophytes, but you can adopt what is approved for Candida to almost any fungus. And as we know, in vitro susceptibilities to fungi may not always correlate with in vivo response, but I sure as hell needed some help because I didn't want to drip amphotericin into the veins of a lovely, otherwise healthy individual who just couldn't get a date because she looked like something from a horror movie. That's what she said. So back to the lab, in vitro sensitivities, it was actually sensitive to ketoconazole. That's what she looks like after taking ketoconazole. She got a boyfriend, she got married, and I got invited to the wedding. It was really, really nice. So, bottom line, what's the bottom line here? You get help. You get as much help as you need. We don't know everything. None of us does. And we all need to cooperate. Find out what kills it. Here's a woman with a tender, it's pointing, it's a boily thing. I mean, you know, and it's MRSA. In Houston, you have to know your own locale. In Houston, over 90% of all staph isolates are going to be methicillin resistant. So the odds are pretty good it's going to be methicillin resistant. And it doesn't matter if she's a teenager who's participating in sports because they get that in the locker rooms, or it's an adult. It doesn't matter if there's trauma or there's no trauma, it's going to be MRSA. But now what do I do? So I culture its MRSA, but you need to know what to treat it with. And you have a wide variety. You have everything from 2 recently approved IV drugs that are about $3,000 a course to doxycycline or clindamycin, generic, or linezolid, which is about $2,000 a course too, even though it's pills. So you have to know your own susceptibility patterns in your own locale. And sometimes, for whatever reason, people in the lab kind of know this, even in the path lab, because they've been dealing with the micro lab or the mycology lab. And so you ask, or you find out, or you call your county health department because they keep statistics on common pathogens like MRSA. What's your susceptibility pattern in your own locale? Know what kills it, and cultures can help you figure out what kill it. That's why we do culture and sensitivity. And you look at those and you follow them to the best of your ability. Now, the other thing is, remember, you have to put everything in perspective. So for a big boil, the most important therapeutic intervention is not antibiotics, it's opening up the space and letting the pus out. There are studies that suggest giving antibiotics are really critical, and there are studies that suggest more that way, that suggest it doesn't really matter as long as you essentially do an incision and drainage. I like giving antibiotics along with my incision and drainage as long as I'm giving them rationally. And I know what's likely to work in my locale, and you should always know what's likely to work in your locale too. Consider your therapeutic options very carefully. Look at this gentleman. He was a civilian contractor working for the US Army in Iraq. And shortly after he came back to the United States, he developed these multiple crusted ulcerations that were painless. And the biopsy showed parasitized histiocytes. So if you look at this, you kind of have to stare a little bit. I've given you some arrows to show you where it's nice. You can actually see these things. So he worked in Iraq. He's got a parasitized histiocytic disease. There's a short differential that involved there, but what would he have most likely having just been in Iraq? Leishmania. Most of you immediately said that. So that's true. But what are your treatment options? Well, it's old world leishmaniasis. It's not mucocutaneous. It's not eating his face away. So one therapeutic option would be benign neglect, because this is going to probably go away. It might leave a scar, but if you did absolutely nothing, probably would do the trick. The standard treatment available from the CDC, you can't write a prescription and send them to Walgreens or CVS, would be pentavalent antimonials given IM or IV. These are not happy drugs to be giving because you can have electrocardiogram changes, you can have massive pancreatitis, and actually people have died from this stuff, along with a bunch of other side effects. You do it if you have to. Mucocutaneous, eating the face away, yes. This, probably no, but you could do it. And then the other thing is these organisms don't like heat. There's actually an approved device that heats these things to the point where they die. Now, it's unfortunately a little uncomfortable, and it does leave blisters and dyspigmentation, but it makes them go away. So you could do nothing. You could give them a toxic drug, or you could heat them. And heating and antimonials are exactly the same. But just for the clinicians in the audience, I thought I would share this with you. There's a drug that was just approved in March of this year. It's been available throughout the world, typical, and just now coming to the United States as a lecithin derivative. It's called Impavido, or its generic is miltefosine. Some of you, if you have animals, might recognize miltefosine because it's used in veterinary medicine. This is a relatively non-toxic drug, and it's given to 100 to 150 milligrams depending on the weight of the patient, and it works for almost all species of leishmaniasis, New World, Old World, mucocutaneous and cutaneous alike. It is pregnancy category X, but other than that, this will revolutionize our treatment for this disease. And because so many Americans, for so many reasons, are in that part of the world where this is not an uncommon disorder, whether it's for war or civilian or government or humanitarian issues, we need to know this is happening. So for the clinician, obtain detailed travel history. For the pathologist, if you think it's weird, okay, you found leishmaniasis, it might be interesting, call the clinician, ask him, did you ask where this patient has been lately? Like, this shouldn't be here in Des Moines, Iowa. So it would be nice to know travel history along with exposure to pets or other animals are the two biggest things I've changed in my 37 years of practice, where I routinely ask about these things too. And that travel history, just like exposure to pets, might have an immediate and direct bearing on your diagnosis, your differential diagnosis, and your treatment. And remember, there's all these other diseases which are slowly but surely coming here. Dengue should be up there now because now we have cases of dengue, and even chikungunya fever has migrated from the Caribbean to endogenous cases in the state of Florida. So things we never thought we would see here are coming here because you cannot put a sign at the border of the United States, please, mosquitoes infected with the following viruses do not enter. It isn't going to happen anytime soon unless we give them all glasses. So travelers travel, people travel all over for all sorts of reasons. Travel history is important to the clinician and the dermatopathologist, and there he was in Iraq. Could anyone else have the disease? I'm going to go over a couple minutes. Is that okay? Could anyone else have the disease? Do you see the pathology here in this young girl's head? And she was scratching her head fiercely. What does she have? Lice. Of course she has lice. So I threw a little rubbing alcohol in her head. That paralyzes them for just a few seconds. Combed it out. Got this really nice louse. Put it in the freezer so it would be immobile. My wife is screaming because that's my child. And put it on a piece of paper so I could take a nice picture of it. And she's saying, "What are you doing? A louse is in the house now." I said, "Well, it was on your child." Okay, all three of my daughters had lice, and yet they're all successful. It really doesn't affect their long-term prognosis. Oh, and this is just a really quick one. Please don't, if you see my wife, don't ever tell her I did this. But they are available in Houston, San Francisco, and Los Angeles. And if you have a brother, nephew who's debt-free and psychologically sound, please see me after the session. So we have all these treatments for lice, right? Lots of lice things. And to be honest with you, this one's expensive and it's not young enough. And they're resistance patterns. And this one's expensive and it's only approved to 4 years. So I like these two the best. The top one's only a single application because it kills the organisms in the eggs as well as the adults. The other one's multiple. It's 2 applications. And it's cheap, but it's kind of hard to use because you have to slather it on. And so anyhow, last thing I want to make a point about lice, consider your therapeutic options carefully. What if the child with lice had a mother like this, who came in and said, "You're killing my child with insecticides," okay? So just keep in mind there are always non-harsh ways to treat some diseases, like head lice. You can put Cetaphil on there, let it dry with a hair dryer, soak it, comb it out, let it dry, let it stay overnight, wash it out. You do it repeatedly, like once a week for 3 weeks. It's the Nuvo method, and the lice die. They basically asphyxiate. So there are other things. There are herbals. There are essential oils that are available that in vitro actually kill lice. So if mom says, "I want something natural," you can go Google, thank God. You can go and you can look up these different things, herbals and essential oil treatments for lice, which actually work. These are probably, the other ones are more efficient, but if mom's going to flip a lid because of it, there's another way. Why did it happen? This, I think, is very important. And why did it happen? Sometimes there's 2 ways between the dermatologist and the dermatopathologist. Pathologists see something you weren't suspecting, should come back to you as the clinician and say, "Hey, is this patient immunocompromised, immunosuppressed, diabetic, cancer patient, because you didn't put that on your path slip?" Or you should put it on your path slip. "Hey, while you're looking at my biopsy, remember this patient has a fasting blood sugar of 500. And so it makes you think about other things when you're sitting there looking at the path slide. So why does this patient have tinea all over the butt? Well, her fasting blood sugar is 352. That patient had a fasting blood sugar of 500 up there, and that guy, he's got tinea of the face, but look at his face. He's Cushingoid because he's got Cushing's disease. This woman, the most notorious plaintiff's medical malpractice attorney in Houston, came in with this. And when I walked in the room, she said, "Do you know who I am?" I said, "Yes, I know exactly who you are, ma'am." And she had these little round, itchy things. She has a new kitten. I told her she had to put her kitten in the microwave. It was the only way to treat the problem. This is a radiation port dermatophytosis. You can actually, through a port, this person was being treated for prostate cancer, through a port, you can actually locally suppress the T cell response enough to get dermatophytosis there, tinea there. So if you were biopsying this because you were thinking, oh, nummular eczema, maybe Bowen's disease, and you're sending it in to Clay or any of his colleagues, you should put, this was a radiation port because it helps them think a little differently. In fact, I wrote up the first case of this. Inappropriate therapy, annular, scaly things a patient's been smearing steroids on, all tinea, tinea. Okay, so good history. Take one and share it with the pathologist. You don't have to hide it. You don't have to be like selfish with the history. It really helps the pathologist or other ancillary personnel. Can it be prevented? These are external genital warts. We have vaccines. Do you know what the vaccination rate for HPV is in the United States among those who are by age eligible? 30%. 70% who are eligible are not getting HPV vaccine. Or let's say you have someone, you're tired of treating them for folliculitis and boils and all this other kind of stuff, and you're thinking, well, maybe it's not that, maybe it's something else, so I'm going to biopsy one of these pustules. Maybe it's Sneddon-Wilkinson's disease or some other pustule or psoriasis or something else. I'm going to send it in, and the pathologist comes back to you and says, yeah, it's folliculitis again. And if it's folliculitis, well, think about repetitively cleansing their environment. A lot of these are spread in the warm, moist areas, like clean your faucets. Maybe they need some CLN. They need to wash themselves and kill some bacteria with a bleach-like scrub every day or once a week. Or maybe they need their sex partner checked so that they're not ping-ponging bacteria. Or maybe they need their pet checked because they might have what's called superficial pyoderma, which can transmit staph to an adult, to a human. So why? Why can we prevent it? Not everything has a vaccine. Think about the environment. Louis Pasteur said, instead of treating things, I think about preventing. The last thing I'm going to say is listen to the patient. The patient may be telling you the diagnosis. This is the same patient. He's got a lesion on the finger. He's got a big thing, big deep nodule on his elbow, and he's got a lot of indurated, sort of not quite paniculitis, but getting there, all over his tummy. He's a 72-year-old Hispanic gardener, type 2 diabetic. He's taking prednisone and methotrexate for his rheumatoid arthritis. Started with the ulcer on his finger. Now he's got fever, chills, 102 plus. He's got a SED rate that's 50. He's got a white count of 24,000. But he's telling you the diagnosis, for goodness sake. He's a gardener. He's got diabetes. He's on prednisone and methotrexate. So, sent off a biopsy. The biopsy was really not conclusive. Special stains for fungus, I might see an organism, I'm not so sure. It's basically what the dermatopathologist told me. So we cultured it and he's got sporotrichosis. It's disseminated sporotrichosis. But he told you the diagnosis. He's a gardener, he's immunocompromised, and he's on steroids, methotrexate, you know, he told you the diagnosis. And in this case, again, molecular diagnosis might be helpful. He was treated and everything went away, basically reducing his immunosuppression simultaneously with treating him with an antifungal. And if you look at the disseminated cases of spora, what are they? They're diabetics on steroids and immunosuppressives. He told us, and he's a gardener, he told us the diagnosis. We didn't need to do anything. Of course we did. But he told us, listen to the patient. Listening to the patient has taken a back seat to high tech. And the patient often tells you what you need to know. I hope you're ready for the next infection in your office. Might come in looking like this, but remember what Hans Zinzer, Brill-Zinzer disease said, however secure and regulated civilized life may become, bacteria, protozoa, viruses, infected fleas, lice, ticks, mosquitoes, and bed bugs, even though they don't transmit disease, by the way, Mr. Zinzer, Dr. Zinzer, will always lurk in the shadows, ready to pounce when bad things happen. Thank you very much for your kind attention.
Well, I'm going to show a sort of a potpourri of some infections now, so histology and some clinicals as well. And Ted went over a little bit, which is great. I'm glad he did, because another good thing about being the director of the course, I can always move stuff around. And since I'm giving about 8 talks today, I can cut and paste one of these until Sunday, so we'll probably just give another couple. And we have Dr. Rao somewhere in the room. He's going to give us a talk at the end of the session on confocal microscopy. So that was a spectacular talk as expected. So we're going to just talk a little bit about how the pathology Ted kept alluding to you can help your clinicians by doing things. And so a lot of these are things we can look at just directly under the microscope, but then as he alluded to, there are other special techniques that we can use. And so I'm going to go through sort of somewhat of a little bit of a encyclopedic view of some selected viral, bacterial, and other infections just to kind of show. And we'll just kind of start off going through some of the viruses. You've already seen a couple already, but herpes virus infection. Again, we've seen some clinicals of this, the closely tight cropped vesicles, and then zinc preparation. This is something you do at the bedside. And we always tell residents when they do the zinc prep to scrape the roof and the base of the blister and everything in the middle, because these cells can be acantholytic. They can float freely in the blister space, or they can adhere to the roof. So don't just scrape the base only, scrape everything and put it on the slide. And if you don't have material in your office, or you're called a consult, you can go down to the laboratory, and they usually have a Wright stain or Giemsa stain they can put on there. You can see the nice multinucleated giant cells here. Very characteristic. And they can also, there are a couple of tests that are available in the hospital that you may not be aware of. There's a direct immunofluorescence test for HSV that can be used. And they can actually just take this and put it on a slide if you take it down there and do an immunofluorescence study and give you a rapid diagnosis. Now, HSV doesn't always look like that. If somebody's immunocompromised, this was an HIV positive patient, had this verrucous crusted plaque, and this was actually sent into us as rule out of cancer. It was not even thought to be infection. The biopsy was done and showed this massive infection with these herpes virus infected cells, a syncytium, if you will. And whenever you see something like this, it should be a clue that maybe the person's immunocompromised, because this is not a normal type of herpes reaction. When you get this many cells that are infected with herpes, think about an infection and find out if the patient's got HIV or something else going on. Sometimes you just see these nonspecific ulcers, and you do a biopsy and it doesn't show any definitive features. This is one where you can do an immunoperoxidase stain. This was an in situ hybridization to herpes virus, which was positive, allowed us to make the diagnosis. He was treated and he did fine after that. Cytomegalovirus, again, we used to see a lot of this back in the AIDS era. AIDS is actually making somewhat of a resurgence, believe it or not. We see patients, a month in our practice that have biopsies that are pristine diagnoses of Kaposi's or other things, and there are people out there that think they don't have to have protected sex anymore, that they have now these heart therapy and they can treat their HIV infection. They get it like diabetes. So there's a lot of unprotected sex going on out there. There are a lot of different types of patterns of CMV infection. In the skin, we usually see ulcers, but you can also see palpable purpura. That's due to usually the extramedullary hematopoiesis like you get in the children that are born with the Torch syndromes. And if you see somebody that's immunocompromised with an unusual suntan in the middle of the winter, it may be due to adrenal infection. This was CMV, infection of the skin due to proctocolitis. They had diarrhea and they were shedding CMV. This was an AIDS patient a few years ago. This was a penile ulcer that was due to CMV. And this is a baby that had this extramedullary hematopoiesis due to CMV neonatal infection. And then this gentleman had CMV adrenalitis, also HIV infected. So just remember those patterns that you can see. Now, just like with herpes, you can usually see the infected cells, but there are other techniques available to you that are available. And if you suspect the diagnosis, you may need to do immunoperoxidase staining or maybe even PCR. This was another example of a viral, of these ulcers punched out in the perianal area. Had this ulceration here. And on higher magnification, you can see that they actually had CMV infecting these cells. CMV usually affects cells like endothelial cells and fibroblasts. Rarely the epidermis is involved, but you can see these nice intracellular inclusions. They're both in the cytoplasm and in the nucleus. They kind of have an owl's eye appearance. Here's some that were circulating in the bloodstream. And then another couple here. And then you can this is what it looks like in a culture. It's called CMV because the cells get very large, cytomegalo, giant cells due to the viral infection. And this is an immunoperoxidase stain directed to it as well. And just like with herpes, you can actually do a smear of a slide and take it in, and they can do this in the hospital lab. Epstein-Barr virus also causes many skin diseases, causes several different things, ranging from ulcers to oral hairy leukoplakia, been associated with cutaneous B-cell lymphomas and post-transplant lymphoproliferative disorders. Again, you can look at the routine histology, but you also may need electron microscopy or immunoperoxidase staining. These are the so-called Lipschitz ulcers that are seen. They're kind of aphthous-like ulcers due to Epstein-Barr virus that usually develops in young women. And here you see one, they look kind of like an aphthous ulcer, but they often get some vasculitis-like changes seen in some of the blood vessels. And this is oral hairy leukoplakia. Also, same virus, two different manifestations, interestingly enough. This looks like some differential diagnosis that usually comes into us is candida or possibly even leukoplakia like a malignancy. And it can occur on the dorsal or the sides of the tongue. It usually gives you this verrucous epithelial hyperplasia with this pallor in the upper part of the epithelium. And here you see these nice pale keratinocytes. And then if you do special stains, this was an immunoperoxidase stain directed to EBV, highlighting these quite nicely. And this is electron microscopy showing the electron microscopy of the virus here. Now switching to bacteria, again, you can get acute or chronic bacterial infections. Again, you can often see these with routine histology, but if you can't see them, you may need to do other techniques like special stains or immunoperoxidase. Septic vasculitis, this is due to bacterial emboli that involves small blood vessels. Usually the classic histology of septic vasculitis versus leukocytoclastic is thrombosis with intact neutrophils versus fibrin with leukocytoclasia. So you can tell them apart under the microscope, and we'll look at leukocytoclastic vasculitis later on. But here you see these distal acral infarcts occurring in this individual. And another example here, these were both due to staph, person had endocarditis. And again, thrombosis, you usually don't see much fibrin here, don't usually see eosinophils. And this is a biopsy. You can notice the acral skin, these thrombosed blood vessels here with intact polys of extravasated red cells and no fibrin. So if you see that pattern under the microscope, think septic vasculitis. Now you say, well, what if I take out a gram stain and do a stain? You may see organisms, especially in some conditions like Pseudomonas, but in staph, especially with strep viridans or something like that, you may not see much of any. Another example of these very distal seated situations here. This was a person that did have Pseudomonas. And again, all of this, these are vessels just totally destroyed. Notice the absence of inflammation. This was a person that had leukemia, was on therapy for his leukemia and was neutropenic and developed Pseudomonas septicemia and ultimately, unfortunately, died from that. So again, immunocompromised patients you may see a lot. Gonococcus and meningococcus you often see very few. Staph you may, but strep almost none. Fungi you may see a lot there. So here's a gram stain. This was a patient that had Pseudomonas, strongly positive. This was another one of a patient with gonococcemia. You can hardly see anything here. And so just remember that you may or may not see too many organisms with your routine staining. Staph scalded skin syndrome, we've already talked a little bit about this. Again, this is that same patient we saw before. Notice the roof of the blister here. So we talked earlier about taking tea in and doing a frozen section. You can take the roof of staph scalded skin and do a frozen section, and you're going to see this change. No epidermal necrosis, normal basket weave cornified layer, and a very superficial split. So if you're dealing with this differential in a hospital consult situation, a frozen section is a great way to do it. We actually do this in our laboratory, so it's something that actually you can make a rapid diagnosis for the clinician. Botryomycosis, an interesting condition where you get a verrucous pyogenic bacterial infection, usually staph. These are colonies of bacteria, and they're usually found in immunocompromised patients. You can usually see the organisms in the tissue. It can occur as this kind of verrucous plaque-like area here. Again, I don't know that you would necessarily think of botryomycosis if you saw this, but you probably would suspect an infection. Or it can look like this, just a very nondescript papule, and something like this be very nondescript, not really have any clue as to what something like that would be. Here you see a relatively diffuse infiltrate in the dermis, and then as we look here, you start seeing these purple clusters of material, and this is all bacteria here. And this, in this case, was actually due to staph. Nocardia, Ted mentioned this in his talk. Again, we see this occasionally in the skin on a biopsy. It's usually not thought to be nocardia, but it's usually in somebody that's immunocompromised. This is a partially acid-fast organism, and it actually, interesting enough, will stain with anti-mycobacterial antibodies. So it's another situation where you can do an immunoperoxidase stain to help you make the diagnosis. Again, you can see this very diffuse, lumpy infected process here in the skin. You know this is going to be infectious. And all these draining areas here with these little white granules, these are probably the sulfur granules due to nocardiosis. This was another patient that was on an immunosuppressive medication that developed these pyogenic granuloma-like areas that were due to nocardia. And another one that almost looked kind of like a ruptured cyst that was due to nocardia. And here's the biopsy. It shows this suppurative granulomatous pattern that we characteristically see with these infectious agents. And lots of suppuration. The routine PAS Phyte stains were negative, but the culture was positive, and we actually went back and did an immunoperoxidase stain for mycobacteria and found a few little areas that were positive in retrospect. But again, just like we told Ted to culture that lesion, a lot of times our special stains are negative. You do need to do cultures. They still remain the gold standard. Actinomycosis, also, this is caused by a gram-positive filamentous bacterium, and usually here you'll get these sinuses containing grains are often seen in areas near the mouth, dental sinuses. Another example, this multiple draining sinuses on this guy's chest wall, and you see this suppurative granulomatous dermatitis, neutrophils, histiocytes, and then in this area a grain was seen, and this was due to actinomycosis. Bacillary angiomatosis, we actually see an occasional one of these every now and then. This is relatively rare. We used to see quite a bit of it when patients were in the HIV era before HAART came about. These are usually severely immunocompromised patients caused by two different organisms of the genus Bartonella, Hinselli, and Quintana that also cause cat scratch disease and trench fever. Does respond to treatment with erythromycin or doxycycline. They present with these interesting little pyogenic granuloma-like vascular papules and the nose here. And they can sometimes be deep, involve the bone, they can involve the spleen, they've even involved the central nervous system. So it is a systemic illness, and you do need to treat it. It can be fatal if it's not recognized and treated. And this actually, not always immunocompromised. This came from a guy that was allowing a parrot to walk on his arm and got bacillary angiomatosis from that. The biopsy kind of looks like a pyogenic granuloma. It's got this lobular capillary proliferation. It's got this sort of somewhat fibromucinous stroma, neutrophils in the infiltrate, and then you'll actually sometimes see some atypical cells with some mitotic figures on occasion. If you do a special stain, a Warthin-Starry stain, we don't usually do this as much for syphilis now as we do with this organism. All of this, it almost looks like artifact or just clusters of these bacteria, very, very numerous usually in these lesions. And then this is a electron micrograph of it demonstrating the organisms microscopically. Now, the chronic bacterial infections, things like AFB, things along this line, again, you can often recognize these organisms with special stains, but in some cases you just don't have them, and you do need to use other techniques like PCR or immunostaining like Ted mentioned. Again, the clinical appearance of these can be quite nondescript, especially when you're dealing with somebody that's immunocompromised. These lesions almost look like a paniculitis. They were due to atypical mycobacteria. And this is a biopsy, and it didn't show a classic suppurative granulomatous process. It really showed an infiltrate of mostly neutrophils in the deep subcutis. So it was a form of an infectious paniculitis here, and the special stain was positive for AFB. Now, sometimes you'll see just one or two organisms. You don't have to have a lot of them to make the diagnosis. Occasionally, just one or two. And I understand that at the AFIP, they have a room where they take a guy, and all he does all day is just look at AFB stains. Then he probably goes home, and he has to either get seriously drunk or take some medications. But that's all he does, and he supposedly finds some organisms every now and then. We don't do that in our lab, but we do occasionally. We'll pull out one of these immunostains. This is another example of this guy, these draining ulcers. So draining ulcers, again, caused by many different things. In this case, it happened to be due to an AFB infection, and this had a more classic suppurative granulomatous pattern with all of these histiocytes here, and his stain was strongly positive. That was a fellow that had MAI infection who was also immunocompromised. Hansen's disease, we always talk about syphilis being the great imitator. Well, Hansen's disease can also be a great imitator. You can see a lot of different clinical and histologic manifestations of this. There's one form known as the histoid form that you may not have heard of that can actually simulate a soft tissue neoplasm, interestingly enough. And here you can see a patient with just a few lesions. Maybe they're somewhat anesthetic. This guy's got more of a diffuse process, beginning to lose some of the hair on his eyebrow. These are both examples of Hansen's. A more widespread form, probably getting more close to a lepromatous pattern now. And the biopsies, again, you can get multiple different patterns. Here you've got a very diffuse pattern where you've got some foamy histiocytes superficially, nodular, sarcoidal, infiltrate kind of deep. And then looking at these under the microscope, usually the greater the degree of inflammation, the greater the amount of sarcoidal pattern, the less the number of organisms. This guy had diffuse polar lepromatous in this case. So just remember, Hansen's, it can look like a lot of different things. And syphilis, we certainly are seeing quite a bit of syphilis. We see at least 1 or 2 cases in our lab every month. So it's not thought of. We're seeing it in unusual settings. There are people that work for money that go into nursing homes with Viagra and actually give it to the men, and then they actually work the nursing home. So we've seen syphilis come out of several nursing homes in several situations, believe it or not. So you do have to think about it. And there's obviously the 3 forms, but sometimes it can look unusual. We see patients who are immunocompromised may have all 3 stages of syphilis at the same time, interestingly enough. This is the chancre, the very firm, painless ulcer that's very characteristic of syphilis. And sometimes they can be multiple. They can be the so-called kissing lesions occurring in the labia. And this is a dark field. That's basically, I don't know if anybody in the room has ever done a dark field examination. When I was a resident, we actually still used to do it. Ted knows what a dark field examination looks like, but probably hardly anyone else in the room does. But these are the little spirochetes, and if actually you do the dark field exam, they're squiggling around under the microscope. It's really amazing to see if you actually have seen it. The chancre looks like this. It almost looks like a just diffuse ulcer, with almost looks like an aphthous ulcer, and a lot of neutrophils infiltrate plasma cells, but you don't have to get that many plasma cells if you do the special stain. This is a Warthin Starry, which was positive, but the immunostain is really much better, and I got a photograph of that as well. We in fact usually refer to the Warthin Starry stain as the worthless and sorry stain in our lab because it doesn't work too very well. But this guy had a diffuse papulosquamous eruption. Again, looks sort of like it could be something like pityriasis rosea. The split papules here, the classic involvement of the palms and soles. So these are classic examples of syphilis. And this is the superficial deep psoriasiform lichenoid pattern that's beautiful with lots of plasma cells. So when you see this, you should think about syphilis, and you can do your special stain, and it's usually loaded with the organisms. This guy had a tertiary gummatous lesion of syphilis. We don't see this as much anymore, but it does happen every now and then. It gives you a very diffuse granulomatous process, and usually if you do the special stain, you can find a few organisms in there as well. Fungal infections, again, same sort of idea. Usually you can identify organisms with special stains, but again, in tough cases, you may need to use some of these other techniques. And actually, this is also something you can do if you're doing a hospital consult. You can actually do a smear, take it to the lab, and they have these antibodies that they can actually do an immunofluorescence stain on as well. We had a case of histo a few years ago that multiple biopsies and failed to reveal organisms, but the smear was positive. So it actually, we were able to make the diagnosis on the basis of the smear that was done in the laboratory. Now, histo can look like a lot of stuff, especially when it's an immunocompromised patient. It can be very subtle. Once again, it can actually have a cross-reaction of these antimicrobacterial antibodies, which is interesting. This was a guy that had HIV a few years ago that had these little acneiform papules on the face. I don't think if I asked anybody who thinks this would be histo that we get too many hands here. It's very subtle, very non-specific. The biopsy of histo can be pretty subtle as well. Again, you see this infiltrate at low magnification that was comprised of neutrophils. There actually was abundant nuclear dust here. And this actually was originally signed out as vasculitis. When the clinician called back, they said there's no chance this guy's got vasculitis. He's got HIV infection. He's got a fever. They were really worried about an infection. Then we went back, looked at it more carefully, and we were able to find the organisms actually within some of these histiocytes that actually were present within erector pili muscles, interesting enough, within the biopsy, and the PAS stain was positive. So histo can be very subtle, and it can simulate vasculitis histologically, so that's something to remember. And here you see the organism stained with an immunoperoxidase stain. Blasto, again, occurs in the north area around Chicago quite commonly, but we see some of it down in the southern part of the United States, the Mississippi areas as well. A lot of these people become immunocompromised, and then they get it kind of reoccurs. They've been exposed at a younger age, and it sort of develops later in life. This guy had all of these nondescript papules and lesions on his face and trunk and extremities. The biopsy showed a suppurative granulomatous dermatitis, and if you look carefully, you can see the organisms within the histiocytes here, the broad-based budding yeasts of blastomycosis, and this is the PAS stain. And you don't always need the special stain. Blasto is one of the organisms that actually will give you a fair number of organisms that you can see. Cocci, again, the lower Sonoran life zone area. Again, these patients often will come in with an URI type of symptoms, and then later on they get immunocompromised and they get a widespread eruption. They can get a lot of different clinical manifestations ranging anywhere from these nodules, like in this patient, to these nondescript ulcers. This also was Cocci, believe it or not. And even this nondescript ulcer here had spherules of Cocci. And the biopsy shows this diffuse inflammatory reaction with caseation degeneration. And you may see spherules. In some cases, you have to look really hard. You can barely make out possibly a spherule in this necrotic area over here, and another one right over here. And then the special stain highlighted it quite nicely here. So just remember these unusual fungal infections in people that have these very nondescript eruptions. Crypto we see probably more commonly than some of these others, especially in immunocompromised patients. We've seen several cases of crypto in people that were on biologics. So a lot of people getting biologics now for psoriasis and things like that. Just remember that crypto can develop, so they can have several different clinical manifestations. One of the ones we used to see years ago was crypto simulating molluscum. They get these waxy papules, and again, it's very nondescript. So just remember, if you see things that look like molluscum, to think of crypto, especially in an immunocompromised patient. Crypto can also look like a paniculitis or like an abscess, like in this case, or even like a paniculitis or cellulitis. So just remember that it can have a large number of different clinical manifestations. Histologically, there are two main forms. There's a so-called gelatinous form, like this, where you see these large areas of pallor. And this is all due to the mucogelatinous capsule of crypto, and these are the organisms here. And then the other form is more like a classic suppurative granulomatous dermatitis, where they don't get as much capsular material. And this is a PAS stain, and this is a GMS stain, highlighting the capsule and then the organism. Sporo, again, Ted showed you an example of this a moment ago. Sometimes we'll get this widespread disseminated type. And usually when you get the lymphocutaneous type like this, where they get a distal injury here, the classic rose thorn, and it just kind of follows the lymphatics up, usually you don't see many organisms in that form because they have a pretty good immune response. This was an HIV positive patient a few years ago that had all of these nondescript abscesses on his face and on his trunk and extremities. And it kind of had an interesting story because he had actually been admitted to the hospital, had been biopsied and cultured, and his culture grew out staph. And so they treated him with staph. They didn't see anything on the biopsy. They just saw what was a diffuse inflammatory reaction. Was discharged home, went home, got worse, and then came back, and we reviewed his original biopsy that had been read, and we actually were able to see sporo, and he had so many organisms they didn't even recognize it. In addition to his staph that was just present coincidentally. These were just some ulcers that he had that were due to his sporo. But here you can see this, again, suppurative granulomatous dermatitis, which is the very characteristic pattern of these deep fungal infections. And all of this area here had too numerous to count microorganisms here. All of these are organisms of sporo in the background. That's pretty uncommon to see that many organisms with sporo when you see it. And this is the GMS stain. You can see these little cigar-shaped bodies are classic for sporotrichosis. And this is the culture demonstrating these little floret structures coming off of these hyphal elements. A few other times you'll get into patients that have, usually these are really immunocompromised patients, low neutrophil counts, and they get these bad conditions like mucor, rhizopus, alternaria. These are the zygomycoses, so you really have to be concerned about these. You don't want to miss these lesions because these are often fatal. Diabetics are predisposed. They get into the nasal sinuses and the brain. They can really cause problems. This was a lady that we had a few years ago that had pemphigus. And she kept telling us that she was going to die. And so we said, well, you know, you're under treatment. We don't think you're going to die, but she could know I'm going to die. Well, she developed these lesions here, and we took a biopsy, and lo and behold, she had this finding. Notice there's not much inflammation here, and that's often the case with Mucor. But this is totally necrotic epidermis, totally degenerated dermis, totally degenerated adnexal structure over here. And she's got all of these aseptate hyphae here of Mucor just growing all through her epidermis, destroying this hair follicle and down in the subcutaneous fat. So if you ever see things that look like straws, you know, on H&E like this, get out and do special stains, because this is Mucor, and it's obviously a very dangerous disease. Here are all the organisms seen with the PAS stain. She nearly did die. She was right, but we put her on, once we made the diagnosis, she got treated with amphotericin, and she actually did well, and she ended up leaving the hospital. But Mucor has got a very high mortality rate, especially in people that are severely immunocompromised. Alternariosis, again, this is another one of these weird fungal infections that can develop, and these can be very nondescript. They get this kind of purplish area. Whenever you see purple, gunmetal gray in the skin, that's not good. So that means something bad is going to happen. So if you're doing a biopsy, make a note of that, send a picture in with it, something. We're going to look very careful to make sure there's not some kind of thing that's causing thrombosis and necrosis and gangrene of the skin. In this case, it was due to alternaria growing, and the reason that it causes that change is that it's not killing the skin directly, it's growing into the blood vessels, causing thrombosis like this. And these people are usually immunocompromised, so they don't really have a lot of inflammatory infiltrate, but here you can see the organism on H&E. So this is alternaria that was just growing diffusely in their skin, and here you see it on the GMS stain. So just remember, if somebody's got a purple area of the skin, beware. Sometimes we get people with more than one pathogen, especially if you're dealing with an immunocompromised patient. Don't just stop at one organism. This was a Mexican-American guy that came up with this verrucous nodule on his knee. I'd been working on the docks down in Mexico, and he came in when he noted that these things were draining these little small black dots. So you've already seen a case of mycetoma just a minute ago. So again, this guy's got something that looks pretty good for that. And you have a biopsy that showed classic features of it. He's got this black brown organism here in the center of his dermis, and this is a nice example of a eumycotic mycetoma. These are all dematiaceous fungal organisms here causing the grain. Well, you know, he also had this area where he had this kind of more caseation degeneration here with his caseation necrosis with all this granulomatous inflammation. So he said, well, you know, it's probably just the mycetoma, but let's go ahead and do a PAS and fight stain just to be sure. He also had a positive infection with the mycobacteria as well as the mycetoma. He actually had two things, and that actually grew out in Marinum. So he had his mycetoma, but he also was sitting around the docks on his hands and knees, and he got swimming pool granuloma. So just remember that you can get more than one organism causing these entities. Now, shifting gears a little bit, we'll talk about parasitic and ectoparasitic infestations. Again, these are things usually you can see by direct visualization of the organisms. I don't usually like to correct one of my speakers at the meeting, but Ted did make a mistake because the gentleman that described leishmaniasis was Scottish. He was not German, so the E is pronounced. So those of you that know the poet Archibald MacLeish, he would turn over in his grave if we called him Archibald MacLeish. So the correct pronunciation is leishmaniasis. So Ted's not here, but I'll rib him about that a little later. This is an organism, again, you can get the New World and the Old World types. Again, transmitted by the sandfly, Lutsamia or phlebotomus. Again, we've actually described in a paper a couple of years ago that it's now moved up in Texas. So just like organisms are moving in from other countries, it's actually moving around within the United States. So this is the phlebotomous sandfly biting somebody, and this is the little life cycle. You see the sandfly comes in, he bites you. These little promastigotes get into your macrophages, and that's what we see when we biopsy the skin. We see this kind of change here. Then these things break loose. They get into these little stages that have a flagellum on them. They travel throughout your body, and this guy comes and bites you again, and lo and behold, you end up continuing the cycle. So this is these are some examples of leishmania. They can give you a lot of different forms. They can give kind of a cellulitis-like pattern, ulcerative patterns, nodular verrucous patterns. And then if you do a biopsy, this will be more of the old world type to give you the very diffuse infiltrate with all of these pale staining cells. It's very characteristic of this pattern. You can see all these parasitized histiocytes. The old world type tends to involve the histiocytes in a diffuse pattern. The new world type, as I'll point out in a minute, tends to give you what we refer to as the Marquis sign or the Ferris wheel sign. So you can kind of tell a little bit apart. And this is a new world type involving the nose, the aspundia, terrible condition where they just destroy most all of their sinonasal passages here, or can involve the lip. So this is new world. And notice the organisms like to line up at the periphery of these histiocytes. Very characteristic, and it's helpful. If you really want to tell it apart, you might want to send it off for PCR or something like that. But if you see this, you can suggest that it's the New World type of Leishmania. We like to call it the Ferris wheel sign because the Texas Star, which is a famous Ferris wheel in Texas at the Texas State Fair, we like to think these are the little organisms at the periphery of that thing. So beware if you ride the Texas State Ferris wheel, because now Leishmania is in Dallas. We get endemic cases in Texas. Protothecosis, this is caused by an achloric non-pigmented algae, Prototheca wickerhamii and Zopfi, so you actually can get algae causing disease in your skin, interestingly enough. These usually are due to some type of trauma to the skin. Usually patients are immunocompromised. They get this sort of nodular lesion, usually overlying a bursa, so it kind of gives you a bursitis. And here you see the main changes are going on pretty deep down here. And as we go to higher magnification, you can see this again, suppurative granulomatous dermatitis. And if you look carefully, you can see these little structures here. These are the so-called morula cells of protothecosis. And here you see this with a little kind of a polarized light transmission. And these are positive with GMS and PMS. And they look like little mulberries. So they're called morula cells, which are classic for protothecosis. Myiasis. We have people that go down to Belize. People love to go down to, on the spring break. They come back and they say, there's a boil in my scalp and it's moving. And sure enough, they'll take a biopsy and the patient isn't crazy. They actually do have this. This is the fly that carries myiasis. It's a human, Dermatobia hominis. It likes people. So it likes to bite people, and then it takes these eggs and lays them, and then you scratch them and you put them inside your skin. And this kind of little booger gets into your skin here, and then here's one that's peeping out here. And here's one that's removed, and it's got these very characteristic little brown rings. It's about 4 or 5 of those little rings, and here you see it again. And this is what it looks like when you actually look at it under the microscope. We probably get a couple of biopsies of this a year, usually around the springtime when people come back from Central and South America. And these are the little spines that correspond to those little black rings you saw. And this is the insect skeletal flight muscle that eventually will turn into the wings of that fly if he were to have lived long enough. And this is his little mouth parts here. So that is cutaneous myiasis. Now, this is an interesting thing that we saw a few years ago, sparganosis. This is a helminth caused by a migrating larva of the cesto genus Spirometro, which is a tapeworm. Well, how do you get tapeworms in your skin? Well, it does happen. People can ingest raw snake or frog tissue, or we have people that when they get like an injury, they take this cool frog meat and put it on their open wound, and they end up getting a tapeworm in their skin, believe it or not. So the old thing about putting meat on a black eye, well, I guess if you put good enough meat on it, it's okay, but don't put contaminated frog skin on your body because you can end up getting infected. This guy presented this little nondescript cyst-like lesion on his trunk here, and this was sent in to us as rule-out cyst. And it turned out to be this disease, which I'll show you the histology of in a moment. But this is the life cycle. Basically, it's this thing lives in these cyclops organisms in the water. They get ingested by snakes, amphibians, etc. And then these actually end up by dogs and cats that actually eat these things. They get excreted, and then it gets back in the water. And then you accidentally either eat this or you put it on your skin, as our patient was doing. And this is the tapeworm, and this is kind of what it looks like in tissue. And this is the biopsy that we saw of that patient. He had this little funny looking thing here that as we get to higher magnification, you can see this is an abnormal organism living in the middle of this guy's dermis. And this is a tapeworm. This is a very primitive worm. This is another piece of the specimen. And here you see the outer portion of the tapeworm. Now the tapeworm likes to take its mouth and stick it in your intestine This floats freely in your intestine, so the food you eat goes right through here and gets in and nourishes the tapeworm, and then they excrete those little bits of the organism. They break out into little small segments, and that's how they procreate. This is the tegmentum, it's called, and you can diagnose these because they have these calcareous bodies. So this is kind of a pretty esoteric disease that I thought you'd enjoy seeing a little bit. So the last couple of minutes we'll talk about ectoparasites. You've already heard about lice. Scabies, very, very common. We see lots of this. Normally you'll have only 5 to 10 mites in an infestation, but in people that have Norwegian or crusted scabies, they can have up to 1 million mites. So that can be very difficult to eradicate. This is a classic pattern, the little lesions between the finger webs. And then the biopsies that we get are when they have this, when they have like a widespread, broad, diffuse involvement, and you don't really recognize that these are burrows, and it looks almost like atopic dermatitis. This is a scraping. You can see the gravid mite here with an egg in the center, and another one, we just see the egg here. And this is a biopsy where we actually have a mite up just beneath the cornified layer, and you get an infiltrate of lymphocytes and eosinophils. So if you see this, you can make the diagnosis pretty straightforward. You've heard about lice already. Can be caused by one of 3 different types. Again, they carry lots of diseases. This is kind of the macula ceruleum of lice here, the little areas where the person has scratched this and they've just got these little hemorrhagic crusts. This is the crab louse. It looks like a crab. This lives in an area where you've got either on your eyelashes or on your pubic area because the hair shafts are about the right size for these guys to grab onto. This is the head louse, which has got a large body, and the knit of the head louse, and the body lice, which kind of has a smaller body and larger sort of prothorax component there. There are other mites that you'll run into, the non-human mite infestation, so you need to think about these when people have these widespread itchy dermatoses. They have usually different morphologies. They kind of look more like a rocket ship or a lancet shape. Some of the organisms that cause this are from the genus Calyatelia or Ornithonisus or Dermanisis. This is a little lady that had a pet rabbit, and she was holding it on her chest, and she loved her little bunny rabbit, and got this itchy red bump disease. And one of our astute clinicians took a Scotch tape and did a Scotch tape preparation and then sent it to us, and this was the Calyatelia mite grasping onto the rabbit hair here, and this is white rabbit hair. And we were able to make the diagnosis of a mite infestation based on this Scotch tape preparation. So just remember that there are other mites and scabies that cause itchy dermatoses in men and women.